Everyone, this is Dr. Naveed Shah with the Home Rehab Network. I have a guest with me today, Dr. Abrar Shah, who is a cardiologist. Um, Dr. Abrar Shah, can you introduce yourself and tell us what you do and what type of cardiologist you are?
I'm Abrar Shah from Rochester, New York. I'm the director of cardiac electrophysiology lab at Rochester Regional Health. Um, so in a layman term, cardiac electrophysiology is electrician of the heart. So every time we have the heartbeat, there's electricity in the heart, which is making the heart to beat 60 minutes, 70 minutes per beats per minute. And that's what we deal with patients with slow heart rate and fast heart rate.
So basically, the electrical system of the heart and different types of arrhythmias.
Yes, so arrhythmia meaning that if your heart is not beating properly, heart is going too slow, or we call it bradyarrhythmias, or if the heart is going very fast, we call it tachyarrhythmias. So there's different treatment option with medication and procedure to control the heart rate, to improve patient symptoms and longevity.
And what about prevention? Preventing cardiac disease or preventing some of these arrhythmias. What would you say?
A lot of cardiac diseases are preventable. There's, of course, some genetic predisposition, but there's a lot of environmental changes or things that we do which put us at risk of having cardiovascular disease. So there are simple things we can do to prevent cardiovascular disease, and diet itself. So if we are on good, healthy diet, that will decrease the risk of cardiovascular disease. Um, the exercise is very important. There's a lot of data for coronary artery disease and also for arrhythmias such as atrial fibrillation, to decrease atrial fibrillation with exercise, and avoid heavy alcohol use and avoid smoking. So these four simple lifestyle changes can decrease cardiovascular disease.
And specifically, anything as far as related to nutrition we should be looking at or be doing to kind of prevent these diseases?
Yeah, there's a lot of data on different type of nutrition, um, and also what particular amount of food you're going to eat, what type of food you're going to eat. So there's a lot of data available on different websites that you can go and look at that. But main thing is to eat in moderation and also avoid very fried food and fatty food. The simple thing is that one of my mentor told me once that if your grandmother didn't recognize this as a food, don't eat it. So there's a lot of modification in the food. So you want to look at the labels. Now FDA regulates the food, so you can look at the labels, what you're eating. But main simple concept is to add more vegetables and fruit to your food and avoid fried food. So simple things you can do. And if you already have coronary artery disease or you already have disease, then you can meet with the nutrition who can help you to guide to what would be the best food for you.
And as far as arrhythmias, what are some of the common arrhythmias that you'll see, especially in context of maybe lung disease?
The most common arrhythmia we see is atrial fibrillation. So when we talk about arrhythmias, we talk about arrhythmias if they're coming from the top chamber, which are called the atriums, or if they're coming from the bottom chamber, which are called the ventricles. So the atrial fibrillation is the most common arrhythmia, probably the number one cause of hospital admission because of arrhythmias. And also there is a very strong link with atrial fibrillation and lung disease. The most common lung disease is COPD or obstructive sleep apnea. Both of those increase inflammation in the system, which promotes atrial fibrillation. It can also increase your thoracic pressure, and that can dilate the left atrium. And both of those promotes atrial fibrillation. So I think as far as our practice, probably 60–70% of the patients we see are atrial fibrillation, which are causes a lot of symptoms, hospital admission, but are not totally life-threatening. But then, you have patients who have prior coronary artery disease or heart disease, and they are at risk of having ventricular arrhythmias or cardiac arrest, which are life-threatening and we need more urgent care.
And as far as treatment options, specifically, let's just say atrial fibrillation, um, obviously there's certain medications, either to slow the heart rate, to thin out the blood, to maybe even prevent or have you go back into a regular rhythm. Um, so there's some medications. Then there's other options. So let's discuss those options as well.
Yeah, when we treat atrial fibrillation, there are four aspects of atrial fibrillation that we are treating. Um, the first aspect is when you have atrial fibrillation, you are at risk of having stroke. So there are different risk factors we look at if patients have hypertension, diabetes, prior stroke. So those are patients who are at high risk, and then those people need to be treated with anticoagulation. In the past, we used to use Coumadin, commonly known as warfarin, but now there are newer blood thinner, and you do not need weekly or monthly blood tests with those, so we usually use Alaquis, the trade name is Apexiban, and there are other in the market available. So that's the first aspect, to make sure patient is not at risk of a stroke, and you can prevent that with a blood thinner. Second aspect, you talked about that some of the patients with atrial fibrillation might go very fast. So we need to slow them down with medications such as beta blocker or calcium channel blocker. Patient might know their common name like metoprolol or cardizem, and they help to control the heart rate so patient is not going very fast. The third aspect is trying to find out why patient have atrial fibrillation to start with. What changes we can make in patient lifestyle or treatment of other diseases which will prevent that. So, we do an echocardiogram, take a look at the heart structure. Is there abnormality in the heart structure? Do the patient have uncontrolled hypertension, uncontrolled COPD or obstructive sleep apnea? A lot of data that if you treat the sleep apnea, you will decrease atrial fibrillation. And then the fourth aspect is that now that the patient is in AFib, what can we do to get them back in regular rhythm? For that, one simple procedure we do is cardioversion. We shock the patient. Of course, patient is sedated. This is not like you see in the movies that people come and shock the patient, everybody's screaming. This is under controlled environment. Patient is sedated. We do the cardioversion, get them back in regular rhythm. And then the question is that how to keep them in regular rhythm. So that's where we have certain medication. We call them antiarrhythmic medication, versus we do a procedure called ablation. Ablation, there are signals from pulmonary veins which are causing atrial fibrillation. So we take a catheter from one of the blood vessels in the groin, go up in the heart, and we get rid of those signals by heating it up with what we call radiofrequency ablation, or cooling it down by what we call cryoablation. And if patient, first we try the medication, they don't respond, so then this is a second line therapy. And in certain patients, it might be the first line therapy to keep them in regular rhythm.
The other question I have is some of the medications for COPD, let's say, for example, albuterol. Is that something that would worsen, someone with atrial fibrillation, or give them some kind of a tachyarrhythmia?
Yeah, so it's kind of a catch-22. So if patient has COPD and we're not treating them properly, so they have difficulty breathing, they are increasing thoracic pressure, so they will be at high risk of going into AFib. So you want to treat them, but some of the treatment does increase your risk of atrial fibrillation, and also might increase the heart rate. So we have had patients that they control AFib, then they have COPD exacerbation, they start using albuterol, and now their heart rate is very fast. So I think this is something that, yes, if you have COPD, you need to be treated. and then we can adjust AFib medication according to the treatment of their lung disease. So we might increase their calcium channel blocker, which doesn't affect the lungs too much, but might slow down their heart rate. Yes, there is treatment for lung disease sometimes which might interfere with heart, and the other way around that people with COPD, if we give them a lot of beta blockers, sometimes their COPD get worse. So you need to treat the patient more comprehensively, not just treat one disease.
And there's also a very good medication for atrial fibrillation called Amiodarone or Pacerone, but not always so good for the lungs.
Right. Amiodarone, we use that in patients with atrial fibrillation to get them in regular rhythm or to keep them in regular rhythm. Long-term use of amiodarone causes pulmonary fibrosis. So this is a medication we majority of the time use for a short period of time. So for example, we have a patient, we're going to schedule ablation maybe 6 months from now, but patient is having a lot of symptoms, so we can give them amiodarone for a short period of time until they get to the ablation. In short period of time use for the medication, the risk of pulmonary toxicity is very low. So as you know, we don't want to use it for a year or in years because then there will be high risk. This is the advantage that we use it in a short period of time and want to make sure that if we are using a patient chronically on on amiodarone, that we do testing, chest x-ray, pulmonary function test, and if we see any sign of beginning of the lung disease, then we'll stop it.
Now let's talk a little bit about cardiac rehab. What kind of patients are you wanting to send? Who are you sending for cardiac rehab, and why would you send those patients?
As we talk about in the prevention, that exercise really helps to decrease the risk of cardiovascular disease. But now, if you already have the disease, you have, for example, coronary artery disease, blockage in the heart artery, you might have heart failure, that the pump is not working well, or you might have atrial fibrillation, which is an electrical problem of the heart. There is studies done in all aspects of cardiovascular disease that once you are stable, that if you do exercise, you can decrease your risk of recurrent myocardial infarction, you can decrease your risk of hospitalization and atrial fibrillation. So I think in our practice, once we stabilize the patient from whatever their primary event is, if a patient have a heart attack, you want to make sure they're not having angina, they're not having chest pain, active chest pain. So once they are stable, we do send them to cardiac rehab. And we have seen a very good response that after patients who stay with the cardiac rehab program definitely have decreased hospitalization, feel much better, and have less risk of having recurrent arrhythmias or myocardial infarctions.
So you would recommend cardiac rehab for a lot of your patients?
Yes, so almost all the patients who already have disease, which could be any aspect of the cardiovascular disease. And even patient who doesn't have the disease, they're coming in with some symptoms. We do the test and we find out, oh, you do not have cardiovascular disease. We still encourage that to go exercise on a regular basis, so then patient doesn't get the same come back with the cardiovascular disease.
All right, very good. Well, I want to thank you, Dr. Shah, for coming on and explaining some of these things to our patients, and I really appreciate it. Thank you very much.
Thank you. Thank you for having us.